this is an important question because, as we know, diseases like psoriasis, hidradenitis suppurativa, atopic dermatitis are chronic diseases. They last a lot of years and they require a long-term treatment. So it's not only a matter of comparison on what is happening the first 3-4 months. We would like to have long-term comparisons on what is happening after 1 year or 2 years. And in order to assess this, it is impossible to have a control group. It is very difficult with a large RCT. That's why the best next thing is such a meta-analysis. So that was important for us to compare all available treatments to find out which is the most efficacious in the long term as well. So first of all, in psoriasis, we have a head-to-head comparison, which is the best. So we have an RCT comparing bimekizumab with secukinumab, and bimekizumab performs better. In HS, unfortunately, we do not have one. So the best next thing was a meta-analysis like this, such a structured comparison. And it seems that when we inhibit both interleukin-17A and F, we get an additional effect compared to inhibiting only interleukin-17A, of course, and that was obvious both in biologic naive and biologic experienced patients. Of course, this is a meta-analysis that has limitations. We do not have a direct comparison. So these data should be seen with caution, but they are the same according to the phase 3 programs. Of course, each clinician will evaluate the patient and decide the best treatment according to his or her approach. So indeed, when we do not have a head-to-head randomized control trial, then we come up with such methodologies, and they have underlying assumptions, and it is important to be transparent. So it is a good approach, but still with limitations. So it seems that these data agree with phase 3 data and clinical experience, but still, as I have highlighted, each clinician will assess each patient individually and will take own decisions regarding what is the best treatment plan for each patient.